So this evening I'm going to talk about some of the Chicago responses to the new paradigm, and specifically around PrEP. And I'm going to talk quickly about a project that AFC leads called Project Ready Set PrEP, or RSP, and what we've been learning and what some of our next steps might be. So first, Project RSP. Basically, we're doing a couple of things. We're providing PrEP education. We want to address there's a huge information gap. People don't know about it, need to know about it, both at our community level and for our HIV workforce. And at the same time, we want to really combat PrEP stigma. It started to come up a little bit with this idea of Truvada whores. There's a fair amount of stigma attached to people who want to use PrEP. And we want to address that and start to change the paradigm so that someone's decision to use PrEP can be framed as a thoughtful, rational, and healthy choice. It's a new form of safe sex, so when we say unprotected sex, we should change what we think about in terms of unprotected sex. So it's a three-pronged approach. We're doing trainings for providers. These trainings include a researcher, a local Chicago researcher, Sybil Hosek, some of you may know her, advocates. We always include a PrEP user, a PrEP provider, so one of our local providers who has a PrEP program, and we always have Gilead in the room to answer all the hard questions. And mostly around access and how to work their website, how to work their medication assistance program. We're also doing community forums where we take it right to the people. We're making them fun. They're talk shows, no PowerPoints like this, even though this is a fun PowerPoint. But talk show, fun with entertainment to try to make it interesting for people. And then the third part of the third tier includes the internet, and it's a platform. Our My PrEP Experience blog is a platform for both people using PrEP to share their stories, but also a place where we've included lots and lots of information. We actually launched that before we got Gilead support for this project, and then we just folded that in and improved it with Gilead support. So thank you to Gilead for that. So make sure you're all paying attention we're talking about tools tonight. So these provider trainings, we try to keep them dynamic. They're interactive. They last about 3.5 hours. We have pre and post tests. We do pop quizzes. We do some small group work. We have them discuss scenarios about what kind of people they might be confronted with and how they would talk to them about PrEP or not. So those seem to have been going well. We're probably, by the end of the year, we'll have done about 150 folks. We're including video in our trainings and at our community events. This is a popular vlogger, a video blogger called Ken Like Barbie. And he has done a fabulous fact sheet, a little video fact sheet on PrEP. You can look him up, I think you should, and check it out. It's a great video. And this is just a quote from somebody at one of our forums who loved the video. We also, I think really importantly, I mentioned this briefly, we always include someone using PrEP in our trainings. I can talk about what it's like to take Truvada or the various aspects of taking PrEP, but it really comes alive for people when it's the real person who's actually experienced it, they've had side effects or not, they've had issues with adherence or not. It ends up being a real highlight of every training, and we bring them up and have them talk at several points throughout. We also include them in our community forums as well. So we're calling these community talk shows because forum sounds boring. They tend to be, we want them hosted by local community people who are not associated directly with public health. So I'm not one of the hosts, because we don't want these to be boring, we want these to be fun. And we include aspects of entertainment, we feed people, which is critical, and we do get a quick eval at the end. At the end of the day, it doesn't have to taste medicine to be good for you. So we don't want them to know they're taking medicine and learning about PrEP, but they're just having a good time. So here's some examples of what a good time can be had talking about PrEP. This was our first forum we did earlier in the year, our talk show, Can a Pill Revolutionize Sex? It was very fun. You recognize Ken Like Barbie. He was also one of our hosts. We chose hosts who had outreach in the community, who had constituency that weren't necessarily around HIV, because obviously we want to reach people who are HIV negative. More proof of how much fun they are. And then we did one just recently where we did a mini ball attached to it. So we got some popular ball guys involved, and they hosted it, Prince Magneto Ebony and Father Memphis Khan. called, the event was called Raw Sex, Did It Just Get Safer? It actually started out as Raw Sex Just Got Safer. There is a difference there. One was a question, this was a statement. This statement led to some people in Chicago losing their mind. So we heard that loud and clear, and it went to Did It Just Get Safer? This still led to people losing their mind, but not as much, and it didn't threaten our entire ball from being shut down. So here's some examples of how much fun they had. This was a lot more interactive than the 30 to 40 set that we did the first time. Very young guys, early 20s. A lot of the house parents were there, which was great. And this is them in action. And these are just some quick quotes that I picked up on Facebook because I'm a stalker. I went on one of our hosts' pages and grabbed some things. So I was just stalking, but they obviously got something out of it, had never heard about PrEP before. During that community event, we actually kind of launched these memes. People who are on Facebook see these memes all the time. They get kind of co-opted by whatever. And a guy who works at our local Project Prepare, a PrEP study, created all these memes that afternoon. So I was like, oh my God, I have to use them. So here's one, and just to get people talking, thinking about it. Here's just another nice quote. People were excited about it, found it informative. Here's another great meme. Some people might recognize that little cat. And this is actually one of the promoters who had never really heard about PrEP before we lured him into our web, who was speaking about his experience on the Facebook page. And yet another meme, first world problems meme. So we found that these were just a way to kind of break the ice, make it a little more fun, and create ways to talk about it. There's 15 other memes that we're now pimping out on our website and our blog. So this is our website. We really do focus on people sharing their personal stories, although I have to say it's hard to get people to share their personal stories because of the stigma. A lot of people don't want to do it. There's been a few, it's hard to get. Some people will do it anonymously. Some people say they're interested and then they don't. I think there's still a lot of challenge in people stepping up and saying that they use Truvada as PrEP. There's a handful of people who are doing it. We also have a Facebook page where we're engaging folks. That is a great screenshot from NMAC, did a whole series of GIFs on PrEP. That's very funny. So we, of course, shared that on our page. We've also been doing a lot of work with others in this room trying to get good stories in the media, the mainstream media, and mainstream gay publications that are not focused on HIV. So a lot of us in here worked on a story that came out in Out that was actually quite good, and also one in the New Yorker that was pretty good. I was slightly misquoted about monogamy, but I'm not going to complain. And there's something hopefully coming in the New York Times soon. So we've been trying to work all the different angles, social media, small press, big press, to start telling the story about PrEP a little bit better. So here are some of our takeaways. First of all, we constantly talk about how things don't work or all the problems with Truvada as PrEP, and it doesn't do this, it doesn't do that. Guess what? Seatbelts ain't perfect either, and we use them. And they don't always work well. You can still get really hurt wearing your seatbelt if you get in a little fender bender. But we still use them, and we still think they're pretty great. So seatbelts ain't perfect, neither is PrEP. The big problem is adults not knowing science. We're seeing a lot of hysteria being spread by community individuals and one key national organization, which will remain nameless right now, but many of you know who I'm talking about, who like to spread misinformation. They're not in a fact-based world, and so so people who aren't really paying attention to science, you can be easily led in by this or swayed by this, especially if you find this organization otherwise reputable. You might be getting services from them, what have you. So we got to get over this flat earth stuff. And we need to be engaging our communities and helping them understand science. You don't need to look at all of Greg Millet's crazy slides with dots all over to get science. You can do it much simpler and still get the main thrust of what things are. We did it in the context of a ball and people who had never heard of PrEP, and they got what they needed to know about PrEP from that. At the end of the day, too, this is all about sex, right? And we focus, whenever we talk about sex, we like to use these words. or we think about these words, or these words come up: danger, risk, and shame. Risk, 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 all the time. And we scare the hell out of people. But what about, when do we talk about pleasure, intimacy, connection, emotion, lust, and love? This is what most of us experience when we have sex. Yes, some of us like things dangerous or risky. That helps with the lust and the emotion, maybe. But really, this is where it's at. If sex was such a horror show, we wouldn't be having it. We wouldn't be a successful species. We wouldn't be in this room having this discussion. So I think we need to get back to this. And I think PrEP allows us an opportunity to start talking about that, to start talking about what it means to not use condoms. We allow heterosexuals to bareback all the time. Our grandmas barebacked. Everyone is in here because our parents barebacked, probably a lot of times. And we don't allow this discussion for gay men to talk about what it means to not use a condom and why it's important. We tend to dismiss it or treat them as reckless and careless. And we clutch our pearls. And I'm just saying, maybe this isn't probably the room that's clutching their pearls, but we shouldn't do it, and we should help our communities stop clutching their pearls too, and getting all judgmental on people, and even crazy. This is the first Carrie and the only Carrie that I care about. She didn't like sex, but if you remember in the movie, she had some very good sex that she liked to talk about. She just didn't want little Carrie doing it. She didn't want little Carrie bleeding, nothing. Well, that was another story. So, all I'm saying is we need, and I stole this idea from someone on some Facebook page, but we need gay men to allow to earn their merit badges other than just using condoms. Gay men can earn their merit badges seroadapting. Gay men can earn their merit badges taking ARV treatment for their HIV infection. They can earn their merit badges using PrEP or condoms. Another thing that we found was a lot of people are hungry for PEP info and wondering where the hell, whatever happened to PEP? Why don't we do it? We don't hear about it. What actually does it entail? Since we started doing the PrEP trainings, we've had to increase what we talk about in terms of PEP because people are hungry for it and don't know anything about it and are kind of shocked that we've really done such a crappy job with PEP. And how can we do a good job with PrEP if we haven't done really well at all with PEP? They're very different. They entail different things, but it's a very good point. We're also finding, and speaking to what David said, in terms of preparedness of our workforce, when we're telling folks, if they're talking to someone who wants to get PEP or PrEP, to show up prepared, to have a link on your smartphone, to have a fact sheet, to have something in hand. We've always had to educate our doctors since the beginning of the epidemic. This is another time. We cannot assume that the person at the other end of that table is going to know anything about this. We have a huge opportunity with ACA. Many, many more people will be getting health insurance, but many of these people many of these providers will have never thought about HIV, will have a hard time spelling HIV, and we have to help them understand what these new modalities are. So some quick takeaways. I mentioned the workforce we've seen in Chicago is extremely interested in PrEP. They may be a little skeptical or hesitant, but they're very open to it, and they want to learn about it, and they want to learn about PEP and want to know more about how they can make use of both of these things. I've mentioned there's still a lot of drama attached to PEP or PrEP. The idea attached to PrEP use, actual PrEP use, PrEP users themselves, among community folks and medical providers. There's still a lot of clutching the condoms as if that's the only thing, despite all evidence to the contrary that it has not been enough for 30 years. If condoms were so damn good, we would all have different jobs. We would be working on something else if condoms were such a great intervention and everyone universally loved them. And David mentioned this. We're seeing denials from docs. One of the things we're doing on our website is called Truvada Track, where we're trying to help people troubleshoot if they're having problems with their insurance or with a provider. And people are going to their doctor, and an infectious disease doc is saying, just use a condom. I'm not going to give you Truvada as PrEP. Someone else saying, well, you're not in a serodiscordant relationship. Young 19-year-old gay black man in Atlanta, I'm not going to give you Truvada because you're not in a serodiscordant relationship. Luckily, these people reached out to us. We were able to reach out to other advocates, and we troubleshot and we changed some paradigms. So I think we helped at the micro level, and we helped at the macro level. These institutions found out what was happening amongst their providers and were able to address training needs and maybe standard operating procedure needs. I think we also, in terms of what we've been doing, there's always this either or. Like if you're for Truvada, you have to be against condoms. And if you're a good condom warrior, you have to be against Truvada. It's both, and we're expanding the prevention toolbox. So we want more things in the toolbox, not less. We're going to keep condoms in there because you know what? They work really well for people. Not everybody, but they work really well when they do. So let's leave them in there and add to it. And finally, I do think the safer sex paradigm is changing, but it's not going to happen without a fight because, there's just a lot of drama attached to it and our own baggage. So those of us who have kind of lived through wartime and saw lots of our address books disappear, and we figured out that condoms worked and condoms saved lives and we got healthier. It's hard for us, for a lot of us in our 40s plus, to think about saying condoms are going to share the stage with some other intervention, or condoms aren't the only thing. It can be very challenging, and I'm finding people who are most challenged by it are people my age or older, who really know, who remember wartime and remember people going to funerals every week, and condoms help change that story. And so I think while I can be frustrated with them, I also am trying to be compassionate, empathetic with them, understand, like I was there too, I get it, but it is a new day and we do have to check our baggage at the door. So finally, we still have a lot of work to do. I think we have a lot of training to do, a lot of education to do, a lot of community awareness talk shows to do. We still need broad community support, so I'm glad that this event is bringing in folks who are not in the HIV fold necessarily to have this discussion, because we're going to need the HRCs of the world. And I am wrapping up. And we need you, everyone in this room. And finally, just to point out that being a PrEP advocate is not easy. It ain't easy being green. So someone talked about a Truvada whore. After I did a gig with the CDC, they did a Google Hangout in Gay Men's Health, the HIV/AIDS Awareness Day. This gentleman, I left his name there because he was fine to do it, and plenty of other people came after me because I had talked about Truvada's PrEP as being a shill for Gilead, a whore for Gilead, a liar, I just gave you a little taste there. Not to boo-hoo cry for me, but just to say that this brings up a lot of drama for people, and I think for any of us who are going to take this on, we have to have a thick skin and move forward for what's best for our community. And that's it. Thank you.
When Sean asked me to come to speak today, he invited me here to talk about some of the key policy developments are impacting kind of the shift in the new HIV paradigm. So you're going to see a very sharp contrast to the presentation you had, because it's not going to be very research-laden, but it certainly is going to attempt to present some of the key, I think, policy opportunities that we're facing and how we can use some of the information that's been shared to date, and certainly through Greg's presentation, to kind of herald some of these key opportunities coming down the pike. I also want to thank Sean Cahill and Ken Mayer and Andrea Karras and all the great folks at Fenway for inviting us here for this great conversation in this important meeting, but also just to share some of the work that NMAC has been thinking about through its newly launched Rise Proud initiative, and trying to look further upstream about how to address both early diagnosis and engagement in care among Black MSM. So to get started, some of the things that we all know, and I'm going to be fairly crude about this because I believe that it's a safe assumption to think that many of us in this room are very familiar about what the ACA will provide to most people living with HIV. So to not belabor those points, I skipped over much of that information. I'm just going to go a deep dive into some of the key opportunities that I believe are coming down the pike. First of all, we know that the ACA alone will expand access to health coverage for millions of Americans, both those living with HIV and those that are HIV negative or at risk for HIV. And I think that is an important point in and of itself, because for the past 30 years, we've been essentially mounting a response that's been largely focused on responding to the healthcare needs of HIV positive individuals. And particularly in the context of the arrival of pre-exposure prophylaxis, more exciting news around microbicides and other biomedical interventions, the access and availability of health insurance for individuals before they become HIV positive, and even for many of us before we develop an AIDS diagnosis, is absolutely critical to our ability to actually achieve this shift in paradigm that we're attempting to shift towards. The other key element that I believe is really captured in both the Medicaid expansion as well as in the establishment of the marketplaces with their different levels of tiered programs that they offer in the marketplace is the establishment of a multidisciplinary care coordination system that's really kind of being shepherded and marketed through both the establishment and the greater utilization of electronic health records, as well as a shift towards more managed care and more use of patient-centered medical homes, which are really a lot of language that's really about using kind of a central provider to coordinate care amongst different specialty providers and multidisciplinary providers to improve both healthcare utilization as well as health outcomes among their patient population. This also has us not only look at how we shift to a new HIV paradigm about how we think about addressing HIV in a population, but also what we need to look like as HIV providers and how we provide care to the patient populations that we work with. If we are not just the individuals that are just doing the testing and counseling, or if we are not just responding to the individual that's HIV positive, what do all of our clinics and what do all of our organizations need to look like going forward to make sure that regardless of what the individual's experience looks like that's walking into the front door, that we're able to point him to the right intervention and right access point to get him either the pre-exposure prophylaxis or preventative services that he needs, or to get him entered into the beginning of a lifelong experience and engagement in HIV care with a HIV specialist or primary care provider. Further, the ACA establishes a floor for essential health benefits, both for benchmark and benchmark equivalent programs through Medicaid, but also essential health benefits for all plans that will be offered through the marketplace. Hopefully one day they'll actually be able to get into the marketplace and actually purchase those insurance plans. Y'all are getting a little too dead for me. I had to bring the energy level up. But once they get into healthcare.gov and they are able to sign up for these plans, everybody will have a base level plan that we never have been able to guarantee for before. Not only will they not be restricted from access to health insurance because of their pre-existing condition, but everybody will have a minimum standard of coverage that we can begin to plan our new system or our new philosophy for how we're going to approach HIV in the United States. And finally, the components of the ACA that we really haven't gotten to yet, but are very exciting developments that we're going to eventually start to have conversations about, is that the ACA requires a whole new level of data collection requirements as well as performance measurement requirements that haven't begun to take a hold yet, but are designed to really look at different ways to modify the clinical environment so that we can improve the quality of care that's received by patients within healthcare institutions and achieve both a reduction in costs over time, but also a dramatic improvement in health outcomes. In addition, we know that Medicaid coverage is going to be a mixed bag for different people across the country, right? Some states won't expand Medicaid, some states will. I think it's also safe to say that this is a political fight that we're having and that we probably don't know what the end game is going to be in terms of Medicaid expansion. Following the gubernatorial elections that occur next November, we might see a lot more southern states expand their Medicaid programs and right the wrongs that they've decided that they're just going to leave low-income individuals outside of healthcare access because they don't agree with Obamacare. Hopefully, rationality will prevail and we'll see more states expand Medicaid, but I keep looking at Leandra and just keeping my fingers crossed. The other thing that we know is that we're going to have a significant expansion of access to preventative services without any cost sharing being passed on to the individual, which means those individuals that even perceived that HIV testing was beyond their reach because they couldn't afford an HIV test, or for those individuals that thought they didn't want to go into an HIV testing experience or enter into care because they couldn't afford either the health care or their treatment. There are new opportunities to reprogram and rebrand their access to healthcare so that they can begin to understand that affordability isn't the same barrier going forward as it was for them historically. And then finally, all programs are required to include antiretroviral coverage. So the conversations that we've had historically around AIDS drug assistance program waiting lists and access to health antiretrovirals for millions of people should not be barriers to our evolution of a nationwide program that establishes treatment as prevention and pre-exposure prophylaxis access points for all MSM and transgender individuals throughout the country. And then finally, looking at the marketplace, the best part about the marketplace is that historically we've always had to make people choose between their access to care and their return to work. Unfortunately, for many people who ended up on public programs either because they developed an AIDS diagnosis or they developed some disability related to their illness, For them to have gotten the advantage of reaching the day where they got protease inhibitors and having their health somewhat restored and having the ability and the dignity to return to work. For many of them, we had to encourage them to stay home because simply returning to work would have threatened their access to benefits and access to health care that they needed to maintain their health care and stay alive. That goes away with the establishment of the marketplace. So we now have new solutions to seamlessly transition people from public programs into broader private provided health insurance programs that can help them re-enter the workforce, reestablish their dignity, but also improve a system and continual entrance into a healthcare environment that will provide them more benefits and expanded coverage that will meet their needs. But all of these developments and key opportunities that are coming with the ACA do not come without significant challenges. Many of us are very concerned about what will happen when many of the individuals that walked into traditional Ryan White clinics will be walking into new healthcare institutions, whether or not the doctors will want to provide the same kind of quality and comfortable services that they've received traditionally through Ryan White clinics. Will anybody in these clinics even want to accept Medicaid? Will they take their Blue Cross Blue Shield? For many people, even in the great city of DC who want to use their private healthcare insurance, many of them have to have PPOs instead of HMOs to see many of the specialist providers in DC. What will the access issues look like even as we transition people into some of these new programs? And what do they mean in terms of how we build this new system of providing treatment as prevention to a wider population of people? And certainly when we look at electronic health records and comprehensive care, what's going to be the provider uptake in terms of their interest in both the technology aspect, and we already have heard from many providers. Fortunately, that's not as much of our problem in the community health centers, who are getting closer and closer every day to almost 100% establishment of electronic health records. But what about the other providers throughout the country who are opposing electronic health records writ large and don't want to enter into a lot of the care coordination mechanisms that we're trying to build to be able to defragment the kind of care that we provide to people with HIV? And then what about affordability? We know that undocumented immigrants will still not have access to either insurance in the health marketplace or Medicaid. What will access to health insurance look like for them? And then finally, how do we avoid coercion of individuals that are living with HIV to be pushed onto treatment because they now have access to health coverage and have access to antiretroviral therapy? How do we maintain a sense of autonomy and agency, though, so that people still understand that it's an individual choice about when they can start treatment and understand really the value of and the benefits of starting antiretroviral therapy, both for themselves as an individual as well as to their loved ones in their community? And then finally, we know that the real benefit behind the Affordable Care Act is that the current system that we have is absolutely not sustainable. It's about to fall off a cliff. We cannot continue to finance the new paradigm that we're all articulating at this meeting based on the discretionary programs that we've relied on for the past 30 years. We can't get Congress to even pass a budget by October 1st. How can we count on them to continue to direct the kinds of resources to the Ryan White program, to the AIDS Drug Assistance Program, and to the HOPPER program that we know are absolutely critical to our ability to provide the necessary services that people with HIV need to be successful? And then finally, I could not talk about the ACA, even though I wasn't asked to talk about the ACA. I had to say a couple of things about the National HIV/AIDS strategy, because I think the ACA in and of itself is a great opportunity if it doesn't have the strategic focus and management and coordination that comes with the National HIV/AIDS strategy. Everybody is aware of the 4 goals of the National HIV/AIDS strategy. The first 3 are the ones that we also always talk about. But the most important one that I think is achieving a more coordinated approach to addressing HIV in this country. We now have a lot of answers, as were presented by Greg in his early presentation. We know that condoms, if used consistently, will work. We know that people, if they are engaged in care and achieve viral suppression, can reduce their transmission likelihood. We also know that if we get people into care earlier, they can achieve optimal health outcomes. But the question becomes, how do we use the current infrastructure that we have? And how do we use key investments well into the future to direct the kinds of services and resources that are going to get people diagnosed earlier and get them into the care system earlier? Part of it is going to come through the HHS core indicators. This is the tip of the iceberg. This is only the beginning of the system in terms of how we're beginning to think about how we impact all programs throughout the country to make sure that they are working collaboratively and independently to achieve a more coordinated and concerted effort to diagnose people earlier and get them into care and get more providers to consider treatment and other dynamic issues that might impact their retention and care and their success with antiretroviral therapy. But the care indicators are instead of taking an environment where we're looking at a lot of different data indicators, we're now streamlining it and looking at 7 really key salient core indicators to take the entire country towards a more concerted way of approaching HIV in this country. Those core indicators are listed here in case you didn't know. And then finally, the more exciting initiative that I think is predicated on a lot of what we'll be talking about. We can't get enough of the continuum of care, right? The continuum of care is a cascade that's really kind of reshaped our brand and our language around how we talk about HIV in this country. With the White House's establishment of the Continuum of Care initiative, it in and of itself is sending a message throughout the country that it is now important for everybody to really think about how they impact, not the cascade, but how they raise the bars all the way from the right side of the graph all the way across to the left side of the graph. How do we independently as providers and as advocates and as public health officials improve early diagnosis and improve retention and care and help to achieve a much larger impact of viral suppression among all people living with HIV? These are some of the opportunities that I hope to further interrogate with you all over the next couple of days, and thank you for your time.
All right, good evening, everyone. And before I begin, I also want to thank the committee and everyone involved for the kind invitation. I agree with Greg. It's always really nice to come back to Fenway, although it's not very nice to always have to talk after Greg. That being said, I'm going to talk a little bit about PrEP and Black MSM. And really, I can't talk about where we are without taking a step back for a moment and talking about how we got here. So I want to spend a little time about talking about the HPTN 061 study, or the Brothers study, because it was a study that helped to lay the groundwork for what we're doing with the current study that we're doing. And out of the work in the lead up, in the community response, the Black MSM community response to the establishment of 061 came the HPTN's Black Caucus, came the HPTN scholars, and it really has laid a groundwork for talking about changing the paradigm about how we do the research. And I want to thank the HPTN leadership at that time, Sten Vermont and Croatia, as well as the investigators of 061, particularly Ken Mayer and Beryl Kobling, for making sure that everyone got invited to the table. So the 061 study was the largest prospective cohort to date of Black MSM, enrolled over 1,500 Black MSM. And that's just the study population. I'm going to go through these rather quickly. In terms of the finding, I just want to, you can read the findings for yourself, but I want to really point out one in particular. In that, peer health navigation, which really wasn't one of the core of the studies to begin with, it was one of the things that came up that we were going to see whether or not if we connected men with peer health navigation, did it make some type of an impact. And the analysis proved that 100% of the men who got even one peer health navigation visit was retained as participants in that study. And what it said to us was, if you go beyond just telling these Black MSM that their lives matter more than just a research subject, and you try to help them with the other things that are going on in their lives, it makes a difference in how they are able to stay and adhere within a research study. So we actually did have some interesting lessons learned, most of which are a little bit anecdotal, but at the time when the study was formed, they attached the Black Caucus to it. I was the chair of the Black Caucus at that time. And I got a call from Sten Vermont one day and said, you know, there's some issues retaining the men in the study. What can we do about it? So we actually had a retention retreat. And we came up with some areas in which to assist the study. And it came out of these three major areas of concern about the burden versus benefit, and some things that the men were saying to us were problems with transportation, the length of the visits, and reimbursement. The intervention delivery, some cultural competency issues, some confidentiality issues, some staffing at some of the various research sites, and then community engagement about how are these men being able to be followed up, being contacted, being found. So we also know that Black MSM prioritize their lives a little differently. So you can't tell somebody, you have to come to a research site Monday through Friday, 9 to 5, if they also have a Monday through Friday, 9 to 5 job. So you're setting them up for not being able to be a participant. And we need to be proactive in how we retain these men in the study. And there was a need for more counselor engagement, mental health services, and the need to address the historical mistreatment of Black MSM. So the Black Caucus really came about to help design, implement, and to interpret the analysis of this study. One of the things that also came out of this study was, in terms of the cultural competency piece, we developed a workshop, the workshop called Presence at the Table, which is a cultural competency workshop for anybody who's working with Black MSM. And we presented this workshop just recently at the USCA conference in New Orleans, and we're getting a lot of really good positive feedback, and we're going to make it more available to people as well. But it was the first study of its type that actually established the Black Caucus. And it was a group of mainly Black MSM researchers and scientists that really were involved in how the study was done and conducted. And it really has become a model. So this is some current members of the Black Caucus. This was the HPTN annual meeting. The mission and purpose, basically to support community engagement activities, advise on staff diversity and cultural responsiveness for the protocol team, provide feedback on study design, resources to the HPTN leadership and the HPTN MSM working group as well. The contributions have been many, but we really have been able to assist the study and provide that cultural context. So I say all of that to say it laid the groundwork for what we're doing now with the HPTN 073 study. And because we knew that IPREX did not enroll enough African American MSM here in the United States, it gave us good proof of concept that PrEP worked. But it wasn't enough information on this subgroup, which is the highest impacted group, as Greg so eloquently let us know, to make any generalizable statements. So we knew that there needed to be a Black MSM PrEP study here in the United States. That study is the 073 study. And while it was never meant to be a direct outflow of 061, it was greatly influenced by what happened in 061. And we're taking those lessons learned into this new study. So what is 073? It is a demonstration project, open label, where we are using FTC and basic Truvada. I'll say the word. It's just a lot easier. It's late. I could try to sit here and tell you I can always pronounce intracytidine correctly, but I really can't. I did that time, though. But we're also infusing it with client-centered care coordination, our version of that outgrowth of the peer health navigation. And I'll explain a little bit more about C4, but it really is what makes this study a little different. And one of the other things that makes this study a little different is that a Black MSM can enroll in our study, but not necessarily be enrolled immediately into having to take PrEP medication. They can decide at any point that they're in the study when they want to uptake the use of the medication or not. We're in 3 locations. We're in Washington, D.C., Chapel Hill, North Carolina, and in L.A. So our study questions is, will Black MSM initiate PrEP? Why or why not? Will they use it on a daily basis? That piece about adherence, we have to get at the adherence piece. We know this. And will Black MSM sexual practices change with the uptake of PrEP? Which is important because we're starting to see some interesting information. I love your slide, Greg, about the advertising about people now being on PrEP, because it led to this whole discussion about, oh my God, are we, with the introduction of PrEP, creating this whole generation of Truvada whores? If you've not ever heard the term, it's a term that's now being put out there. Men who are on PrEP who are now, with a perception, being more sexually promiscuous. Don't necessarily think that's true, but sometimes this stuff is about perception. Is it going to be acceptable to have PrEP administered at local healthcare facilities using our client-centered care coordination? So we were tasked very early on in how we designed this study to make it real world. And they kept coming back to us saying, it has to be something that we can roll out at the end. Well, hence the whole conversation around how do we conduct something called C4, a client-centered care coordination. And it really is a clinical model that's going to maximize resources and expertise to help develop a unique plan for each individual. So it really isn't something that hasn't been done before, but we're packaging it a little differently. And every single individual enrolled in a study is going to have a C4 component. And it's basically care coordination, a client-centeredness approach, and a provider for clinical oversight. That's what C4 is. It's not uber special. So again, these are the 3 sites. We're going to enroll 225 men across the 3 sites, 75 at each. We're going to be doing interviews for those who choose to uptake PrEP, for those who do not initiate PrEP, and then for those who are conducting the C4 visits, because we also want to know how is this going to be actually rolled out. So key to all of this has been our community engagement. Community engagement has really shaped the rollout of 073, especially for our messaging, which is meant to be empowering and letting the men know that they actually have a choice of taking PrEP. And that's been really important. And we've done community engagement and local representatives at each of the 3 sites as part of the site's initiation into before they are allowed to do any studies. So this is our branding. My life, my health, my choice. And you can actually see the whole campaign on the HPTN's website and its rollout, and we have a really nice video as well. So I want to acknowledge my co-PI, Dr. Dara Wheeler, and our study team. And what is significant about this team is you're looking at the first team in HPTN's history to conduct a study. This study is being done for Black MSM. It is also being conducted by 4 Black MSM. This is the current chair of the Black Caucus. And I hide in public. You can always find me. Thanks.
Thanks. So I have the unique privilege of having Greg presented half my slides already, so I can go pretty quick through some of these. But first I want to do a snap audience, and actually he did it far better than I could have done it. So I want to conduct a snap audience poll. So how many of you have ever missed a dose of antibiotics? Today? Today, okay. Thank you for sharing. You don't have to raise your physical hand, you can raise your mental hand on this, but how many of you have ever been less than perfect in your sexual health choices? Okay, so me too. And one of the reasons why I feel like I am one of many ideal community presenters on a community perspective is that I actually would have been an ideal candidate for many of the interventions that we've talked about. Including PrEP, but also because many of my partners were HIV positive and on antiretroviral therapy. So it has a place near and dear to my heart. Let me go into the presentation mode here. So as Greg said, HPTN 052 showed that there was a 96% reduction in risk of HIV transmission when the HIV positive partner was on antiretroviral therapy. And actually, if you do a slightly deeper dive of the data, one of the things you find out is that the one transmission that occurred in the group that were taking antiretroviral therapy happened before the person's viral load actually became undetectable. So we could, in some sense, say that it's 99% effective under those unique trial circumstances. But as Greg also pointed out, we don't know how this is going to work in MSM at all. We just have no clue. And as he also pointed out, there are many reasons to suspect that the results might be slightly different. There are a couple of studies that are rolling out. One is called Partner. The other is called Opposites Attract. Neither one is going to give us a perfect indication of how well this works in MSM, but hopefully it'll add to the field and add to our knowledge. There are also, as he pointed out, some really tantalizing data. In San Francisco, for a variety of reasons, as he already pointed out, we've gotten a near 2 times reduction in new HIV transmissions. At the very same time as antiretroviral therapy is going up, at the very same time as the average CD4 count upon which someone is diagnosed is going up, and also at the same time as, or actually at the later time point, as we introduced universal treatment for people regardless of their CD4 count. So there are a variety of reasons why we're having the success, but as he also pointed out, unfortunately in the United Kingdom, we don't have the same result, and we also don't have it in Australia. So it's not the panacea that maybe some might hope. Some of the challenges include the fact that a substantial portion of people don't know their status. And if you don't know your status, you can't be on treatment. And there is at least a disputable number of people where the infection is happening among people who are acutely infected. And one of the things that's unique about folks that are in the acute infection portion and those that don't know their status is they can be part of sexual networks that in themselves cluster together and really ramp up the likelihood of someone becoming infected who gets involved in those sexual networks. And a sexual network doesn't necessarily mean that you're having sex with a lot of people. It means you only had to have sex with one person who happened to be involved in that sexual network. There are new programs that are looking at earlier intervention, that are looking at trying to diagnose acute infections as they occur earlier. But this has been a real challenge. In North Carolina, it's one of the pioneers of looking for acute infections, and they've had a really, really difficult time. We're trying to do some of that kind of work in other cities, but it's a real challenge. Also, some in the community have expressed a real concern about coercion, that are people going to be convinced or challenged or insisted that they go on antiretroviral therapy, even if they personally don't believe it is of their personal benefit in the moment, but simply to protect their HIV-negative partners. So that is one of the concerns that the community has put forward. There was a recent treatment as prevention conference. Jose actually was one of his IPAC was one of the sponsors, and a new sort of European set of guidelines around HIV treatment as prevention was developed. And that was one of the key tenets, is that they didn't want to coerce people to start treatment. And treatment guidelines are all over the place globally. And I can't imagine how much this contributes to the confusion, not only among the part of people living with HIV, but also among providers. In the United Kingdom, they say wait until 350. Here we say start immediately. So where do we fall? And there are arguments about the strength of the evidence on both sides. And interestingly, in a survey of HIV care providers who themselves describe themselves as HIV specialists, what we found is that only 49% of them said that they would prescribe antiretroviral or recommend antiretroviral therapy to someone at high CD4 counts if the primary reason was that they were putting others at risk, so or engaged in behavior that might put others at risk. And so providers themselves, I think, are not necessarily helping in this particular matter. So the other thing that is a little bit complicating is what are the actual recommendations for how you might prevent transmission. And with the British HIV and AIDS Association guidelines, they recommend that someone be undetectable for at least 6 months, that they have no STDs, and as we heard, that's going to be a challenge, that there needs to be frequent monitoring of viral loads, And the question is, how important are condoms in that perspective? And what we know is that they're actually quite important. And to the health of the person living with HIV, Hep C is another growing concern, where we're seeing these outbreaks of hepatitis C among gay and bisexual men who are HIV positive in particular. But also men who are becoming infected at the same time. They find out that they're HIV positive at the same time as they find out that they're HCV positive. So switching gears to PrEP, which is another form of treatment as prevention, how is it being used and what has the uptake been like? We talked, we heard that a lot of men don't know about it. Gilead did a survey, very complicated survey, to try and figure out how many people were actually using PrEP or had used it. And what we found is that about 1,750 people had used it since about mid-2011, which is a year before it was approved. And that the uptake since approval has actually not been that significant. It's been moderate. We found, to many people's surprise, that half of all scripts were written for women, and a substantial proportion, I think it was 34%, were written for the southeast part of the United States, which unfortunately has lagged behind often in terms of provision of service, in terms of access to health care. We know that one major Medicaid market, Florida, prohibits the provision of Truvada as PrEP. There are two others that require prior authorization. Sorry, Sheldon, are you in Florida? I don't mean to pick on you, I'm sorry. Two of the Medicaid markets require prior authorization, so the provider has to jump through hoops to get the prescription. And we also know that the two of the largest insurers in the United States also require prior authorization. And interestingly enough, when they were asked why, they said it was to protect the individual. They wanted to make sure that people were actually getting tested, that people were actually understood the consequences of going on PrEP. But there are some concerns among some of us that this is just a slippery slope, and that there are other providers that are going to require much more onerous types of prior authorization. And if somebody is brave enough to go to the doctor and say, hey, I need PrEP, how many hurdles do we want to put in front of them before they get it? There are also anecdotal evidence, and Jim can talk about this to you after the presentation, that providers are one of the biggest obstacles right now, where we have people who want PrEP, they ask for it, they go to their provider, and the provider says, no, just use condoms. Well, duh. If that message would work, it would be working, but it doesn't. And we're also really worried that access outside of the demonstration projects, which are sort of the real-world experiments of how PrEP is going to be taken up, is what's going to happen to them when those demonstration projects end. Al Liu from SF has been, and Stephanie is here, has been wonderful about asking this question, because the San Francisco demonstration project, which was the first out of the gate, is also going to be the first to close. And what are we going to do with all of those individuals that are already taking PrEP, let alone those who want it afterwards, who are not a part of the demonstration projects? So this is something that Project Inform, this is near and dear to our hearts, that we're going to try and work on in the coming years, is how do we ramp up availability of these interventions? And then in terms of cost and access, it is $13,000 retail, but very few people are actually paying that. We think that insurers are probably paying about 20 to 30% less, and that Medicaid programs are probably paying about 40% less. As I said, two of the largest insurers have prior authorization. One of the issues is that coverage for doctor visits and diagnostics might turn out to be the biggest hurdle, because we can probably get PrEP from most people who need it, but getting them in to see the doctor and getting coverage for that and having the healthcare capacity to deal with that is going to be an important hurdle. Gilead has a patient assistance program for people who have low income and can't get it otherwise, but uptake of that program has been extremely low. Many people haven't used it. And right now, as I said, providers seem to be among the biggest barriers to uptake. So thank you.